Presentation is on. Okay. Uh,
Just to remind everybody that this session will be
yes.
chaired by me. I'm Dr. Ravindra, and my co-chair is Dr. Bikram Gajre, who is an associate professor in neurology from the Institute of Medicine. He shall be chairing the next with the next speaker, Dr. Krishna Nana. So, Dr. Dipesh now, please.
Okay. Good evening, everyone. It is very delightful to have you all in this program, which is organized by National Neurology Association of Nepal. And I am Dr. Dipesh Saki, Assistant Professor in Neurology Department. The topic that I have is thrombolysis in stroke. So we'll start with the definition, the background. Stroke is a rapidly developing clinical sign of focal disturbance of cerebral function, lasting more than 24 hours or leading to death with no apparent cause other than that of the vascular origin. In simple form, we can tell it's a neurological deficit secondary to the vascular insult. So this is a definition. So generally, we divide the stroke into two types. That is the ischemic stroke and hemorrhagic stroke. Ischemic stroke accounts for 85% of the cases and hemorrhagic about 15% of cases. This is basic. So epidemiology, WHO, according to WHO, there are 15 million people suffering from stroke worldwide each year. Of these, 5 million people die and another 5 million people permanently disabled. So, on note that stroke is the second most common cause of death in the world after coronary artery disease. You can see this among the top 10 global cause of death in 2016. Stroke claims more than 5 million people of death. So it is the burden in the whole world population, the stroke, which is being a non-communicable disease. on this is the data, US data. On average, someone in the US has a stroke every 40 seconds. So while we are taking a class of about few minutes, there are about few cases in the US as per this data. On average, someone dies of stroke every 4 minutes. We have a very limited data of Nepal. Jaya Stroke Foundation had earlier estimated that 50,000 people suffer from the stroke every year in Nepal, and 15,000 people die of stroke annually. So the few studies are only done, and the most reliable, I think, this is the one which is done in 2006. So now we are talking about thrombolysis. Why thrombolysis or reperfusion therapy is important? We can see over here the picture. There is a dark black circle. This is the area of the brain which is destined to die. This is a ischemic core. This is not reversible. This is irreversible. But talking about the gray area of the brain, this is the area where there is a decreased perfusion of blood in this area. If we can reperfuse, if we can thrombolyze and increase the circulation in this area, we can save the part. This is known as penumbra, and this is a salvageable brain area. Hence, the reperfusion offers the potential to reduce the extent of ischemic brain injury and thus reverse neurological impairment. So, the treatment to time is very important in this. So, by this time, we know time is brain. So, in this chart, we can see that per stroke, a person is going to lose more than 1.2 billion of neurons, and more than 7,000 myelinated fibers are lost. And the age is accelerated by 36 years. See the per stroke, talking about per second, the patient is going to lose more than 32,000 neuronal loss, more than 230 million synapses loss, more than 200 meters of myelinated loss, and the patient age per second accelerates by 8.7 hours. So we can see the burden of the disease according to the time. So time is very important for the treatment of the stroke patient. So having said that, average time of the presentation after the stroke in Nepal is 28 hours. Generally, people present to us after a day or two. Only 16.5% of the patient presents within 4.5 hours. See, we have a very narrow therapeutic window, and we get less amount of people in in our hospital. This was a study done in teaching hospital. Now we'll talk about the thrombolysis in stroke. We got into the thrombolytic proper. So NIH recommends that door to needle time has to be less than 60 minutes. Door to needle time is the time when the patient arrives to the hospital till the patient receives the IV thrombolytic therapy. This is the golden hour for evaluating and treating the acute stroke. we can see this chart where time 0 is the patient when reaches to the hospital in the emergency department. Less than 10 minutes, the patient should be evaluated, done the lab works, history, and the stroke team should be activated by then. Less than 25 minutes, the CT scan should be initiated, and less than 45 minutes, CT scan and lab interpreted. Less than 60 minutes, RTP therapy should be started. So this is the door to needle time for a developing country like us. We have a limited resource and manpower. But in the developing countries, they are still practicing the door to needle time is less than 30 minutes. It is a standard for developed countries. They do the door to needle time within 10 minutes. The case is evaluated by the stroke team, and all the investigation are sent. Within 20 minutes, the CT scan should be initiated, interpreted, and 30 minutes, the thrombolytics should be started. We should always target as early as possible, less than 30 minutes or more before 60 minutes, because time is very important for the treatment. For each 15 minutes, the reduction in time for the treatment of thrombolytic, we improve the patient mortality by 4%. We improve the patient complication of intracerebral hemorrhage by 4%. So the each minute is very important. You know that 1.9 millions of neurons are lost in 1 minute. So due to needle time should be minimized as possible. So now in the first 10 minutes, the assessment goals includes assess ABC, airway, breathing, circulation. The patient may require ventilator in case of severe stroke or when there is a bulbar involvement, bulbar stroke. And vital signs should be monitored, including blood pressure, temperature, respiratory rate, pulse. Provide oxygen by the nasal cannula. Mark all patients should may not require the oxygen therapy. We should aim to make the saturation more than 94%, and those people may require the oxygen therapy. Obtain two large bore IV access. Obtain blood sample, including CBC, electrolytes, troponin I, because most of the time the stroke patient may have a coexisting MI. Coagulation studies, including PTINR, APTT, this platelets. Obtain 12 lead ECG, because arterial fibrillation is common among the stroke and they have to be monitored as well. Check blood sugar, treat if indicated. The very easily investigation that will be done, and the only required for the thrombolytic therapy, the investigation is blood sugar. We can do the blood prick test and treat if it is necessary. The patient should be kept in the supine position in non-hypoxic patient. In the supine position, the patient cerebral perfusion is maximized, but make sure the patient doesn't have is not toxic, is not unconscious. There's no symptoms of increased ICP. This should be considered during the patient when kept in supine position. By this time, 10 minutes, alert stroke team, neurologists, radiologists, CT technicians should be alert. Perform a neurological screening test, that is GCS, NIHS score, and a routine neurological examination. By this time, by 10 minutes, we should order a CT scan brain without contrast. So talking about NIHS scale, it's a National Institute Health Stroke Scale. Why do we do it? It is a standardized stroke scale severity. What it does is quantify our clinical examination in terms of numbers. That will help us to communicate between the doctors. We tell them this is the NIH score. It also tells that whether the patient is neurological improving or deteriorating. Deteriorating when deteriorating, is there any problem? Am I audible?
Yeah, yeah.
Yeah.
Okay, okay. Determine the patient neurological. It NIHS also score helps in determining the patient neurological status, and it also helps us to know that whether this is a high risk thrombolytic therapy or not. Otherwise, if there is more than 25 of NIHS score, then we tell it's a high risk thrombolytic therapy. So, what is NIHS score? It consists of a neurological examination parameters that are high mental function, cranial lobe examination, cerebral examination, motor examination, sensory examination, language, and cortical examination. These each and every parameters are given a score from 1 to 3, and we all take this in numbers and we tell the severity of the stroke disease. If it's between 0 to 4, we call it mild. If it is between 5 to 15, we call it moderate. If it's more than 15, then we call a severe stroke. So this is a start which we can carry out with our stroke protocol, as well as we can have this in a mobile app as well. So this NIHS score, so I will be not be able to make you understand about the NIHS score assessment. However, I'm going to give you a link which is very nice and very nicely explained. Explained. You can check this site and you get it in the YouTube. And this examination is followed by most of the neurologists. So please, you can write it down. Okay. Within the time goal of 25 minutes, immediate neurological assessment by the stroke team should be done, and less than 25 minutes to 45 minutes, the CT reporting should be done. It has to be known that the patient reporting, is it hemorrhagic or ischemic. So, non-contrast CT scan of brain is more than enough for early diagnosis of stroke. It is the initial imaging modality in hyperacute stroke. Maybe in hyperacute stroke, the CT scan may be normal, but by the clinical judgment, by the sign and symptoms, we do the diagnosis clinically. CT scan is widely available, quick, easy to perform. It accurately identifies hemorrhagic versus ischemic. So, intracranial hemorrhage or subarachnoid hemorrhage can be distinguished by this modality of imaging. MRI can be also done, but if it takes time to do it, we are not doing MRI. We will be happy with the CT scan, non-contrast, and we go for thrombolytic therapy. But however, MRI can be done, easily available. It can detect as early as 39 minutes of stroke. DWI and ADC sequence can detect an early infarction. This is a DWI where you can see the hyperintensive lesion, and corresponding ADC there is a black lesion. It can catch early as 39 minutes of stroke. The other is CT angiography of head and neck. It should be done in all the patient with ischemic stroke, but we should not waste our time doing CT angio along with CT plane. First, do the CT plane, see the lesion. If the patient is eligible for thrombolytic, do thrombolytic, then go for CT angio. CT angio helps to detect the intracranial large vessel stenosis and occlusion with high accuracy, which may be resistant to thrombolytic therapy and helps triaging for mechanical thromboectomy. If there is a large vessel occlusion, these are less responsive to thrombolytic therapy. So the patient thrombolized who have been thrombolized may go to thrombectomy therapy later on, and which will be helpful by doing CT angiography. So within the time goal of 45 minutes, treatment decision should be done by the specialist. By this time, indication and contradiction of the thing thrombolysis should be sorted out. This will be done by Dr. Krishna. Repeat neurological examination should be done whether the patient is high risk thrombolysis, or patient is the fate. What is the fate of thrombolysis? We can know by the NIHS score as well. So blood pressure management, or the very important is high blood pressure. Before commencement of LTPs, we should have a target blood range below systolic blood pressure 185 and diastolic pressure 110. If it's more than this, we use a laboratory injection 10 to 20 mg IV over 1 to 2 minutes, followed by an infusion at 2 to 8 mg per minute, not to exceed 300 mg per day. Nicardipine infusion 5 mg per hour, titrate up to 2.5 mg per hour at 5 to 15 minutes interval. Maximum dose is 15 mg. Other drugs that can be used is enalaprate, hydralazine. If the BP is not controlled with this, then we can add sodium nitroprusside. So you should be careful with sodium nitroprusside because it has a theoretical risk of increasing the intracranial pressure. So if the diastolic blood pressure is still 140 mmHg, then we use sodium nitroprusside with the time goal of 60 minutes. Now, by this time, we should have started intravenous antipase administration. For these, two wild boar cannula has to be placed in the brachial veil, preferably. Body weight should be determined. The dose of LTPase is calculated at 0.9 mg per kg of the body weight. It should not be given more than 90 mg. 10% of the dose is given as an intravenous bolus over 1 minute, and the remainder is infused over 1 hour. So this is the protocol. So, what are the things you should monitor during and after the thrombolytic therapy? Vital signs, again, such as BP, temperature, pulse, respiratory rate, neurological status, NIHS score, pupil, GCS, more hand grip, sensory finding, all should be checked. every 15 minutes during and for 2 hours after the LTPH treatment, then every 30 minutes for 6 hours, then hourly for 24 hours from the start of the LTPH treatment. So these are things that to be monitored. Blood pressure should be maintained at or below 180 by 105 mmHg during the first 24 hours. If not be able to control, start the antihypertensive in infusion as we discussed before. A follow-up non-contrast CT scan should be done 24 hours later and before starting the treatment of antiplatelet anticoagulant agent. So CT scan should be done 24 hours of the treatment. Things to be avoided. So what things are to we should avoid is anticoagulant, antiplatelet, maybe warfarin, heparin, aspirin should be avoided for at least 24 hours. Intra-arterial catheters, indwelling bladder catheter, nasogastric tubes should be avoided at least for 24 hours until unless very necessary. If it's necessary for catheterization, we can do only after 1.5 hours post thrombolytic. Avoid IM injection for 24 hours. Avoid vein puncture for 12 hours. Avoid suction whenever possible. Caution when giving mouth care. So these are things you should avoid and should be careful of. So when to stop the RTPA infusion? If there is anaphylaxis, generally orolingual edema, sometimes it's mild form, it's sometimes very severe form. BP systolic less than 100 mmHg, sustained BP rise to more than 180 by 105 mmHg for 5 minutes even after treatment, associated with neurological deterioration of any sort. Major systemic bleeding, generally gastrointestinal or genitourinary severe bleeding. Otherwise, minor bleeding, oozing blood from the vein or catheter site is not a indication to stop LTPs. If there is a neurological deterioration of GCS more than 2, the GCS decrease more than 2, then we consider as a neurological deterioration and we need to stop RTPA. So indication for urgent CT scan, when we do a urgent CT scan, when there is a sign and symptoms of intracerebral hemorrhage, one of the very dreadful complication is intracerebral hemorrhage. And when we feel the sign and symptoms of intracerebral hemorrhage or raise ICP, then we start to a urgent CT scan. New or worsening severe headache. The symptoms are acute hypertension, nausea, vomiting, agitation, seizure, a neurological deterioration of GCS by 2 points, NIHS increased by 4 points, or new neurological deficit contralateral to the stroke. So now we come to the complication. Generally, the RTPA has a complication, few complication. A very dreadful and fearful complication is the intracranial bleeding. Intracranial bleeding presents with clinically two types. We have symptomatic intracranial bleeding, which occurs in about 6%, and fatal intracranial hemorrhage, which occurs in 2.8%. So this is a CT scan of a patient, our patient. We did a thrombolyte in this. It's a 65 years male who presented to KMCTS with NIHS score of 19. And the patient has a history of stroke 1 year back. And we did a thrombolytic therapy. And unluckily, the patient had this severe intraparenchymal hemorrhage. The patient landed up being fatal intracranial hemorrhage. We tried treating the patient, but we could not revive the patient. The patient expired, and the intracranial hemorrhage was seen after 5 hours of RTPA. So now we talk about the management of symptomatic intracranial bleeding. So stop antiplatelet infusion at once. We send a blood investigation, CBC, PTINR, fibrinogen level, cross match, blood group type, coagulation studies. Urgent non-enhanced CT scan should be done. Cryoprecipitate, 10 units infuse over 10 to 30 minutes. Additional dose should be given to maintain the fibrinogen level below 150 to 200 mg. Generally, in our context, we don't get cryoprecipitate that easily. Actually, cryoprecipitate is the concentrate form of fresh frozen plasma, which is rich in factor 8. So what we do in our context is we don't get cryoprecipitate. We have arranged a fresh frozen plasma 10 pins. So generally, a patient may require fresh frozen plasma 15 ml per kg. This can be stored up to 6 months. Third, and we use it. We have prepared fresh frozen plasma at least 10 units in our system. And if the patient has bleeding, we can't get cryoprecipitate, we use fresh frozen plasma 15 ml per kg, and we give a platelets of 6 to 8 units, irrespective of the platelet count. If the platelet count is less than 1 lakh, we should give 6 to 8 units. But even though if we don't have, if the platelets count is also normal, we have a symptomatic hemorrhage, we give this platelets not for the platelets thrombocytopenia, but we give for the platelet dysfunction. The antifibrinolytic agent can also be used. We used tranexamic acid 1 gram IV bolus over 10 minutes, followed by 1 gram IV over 30 minutes. Or we can also use another antifibrinolytic agent, such as, which is not that commonly found, aminocaproic acid 4 to 5 gram IV during first hour, followed by 1 gram per hour for 8 hours until bleeding control. So we generally go with the tranexamic acid, but if we have this, it's good as well. Hematological and neurological consultation should be done. Supportive therapy, including BP management, ICP, mean arterial pressure, temperature, and glucose control, should be done along with the other treatment. Now, the second complication is orolingual angioedema. It occurs in about 1 to 8%. Most of the time, it is transient and mild, but rarely it is severe. So, what we do that time, we discontinue IV ATPase infusion and hold ACI. Most of the time, orolingual edema is seen with the patient with ACI, taking ACI. So, we need to stop ACI. Give IV methylprednisolone 125 mg stat or injection hydrocortisone 200 mg IV stat. Give IV diphenhydramine. This is the antihistamine. Give ranitidine 50 mg IV or famotidine 20 mg IV. If the further does not improve and increase the angioedema, we give adrenaline 500 microunit IM. So, talking about oral-legal angina, the dreadful complication is when there is an airway compromise. Whenever there is edema limited to anterior tongue and lips, intubation is not necessary. But when there is a rapidly progressive airway compromise, generally within 30 minutes, that poses risks for requiring intubation. What we do, the very good protocol is awake fiber optic intubation. This is optimal. In this, the patient is not paralyzed or not fully sedated. Mild sedation is given with local anesthetic, and there is a direct visualization of the tract, and there with the guidance of the scope we did the intubation. Hence, the bleeding complication is low and easy. This has to be done with a very specialized team. Now we talk about outcome. For every, you can see this chart, there's 100 people. For every 100 people over here, they treated with TPA, 32 patient benefits. These are the 32 patients who benefited, and 3 patients are harmed. Among these 32 patients, 13 patients, which is a dark green, 32 patients are normal or near normal, and the remaining are doing really good. And these are the white patients, which are colored white. They didn't show any better. Among these 3 people who are the worst situation, among one will die or have severe disabled, and 2 of them have a severe complication. So looking on to this and the disability that the patient will have, doing thrombolytic is very justified. So other IV thrombolytics, apart from alteplase and tenecteplase, the benefit of other fibrinolytic agent is not proven. So hence it is not recommended. So alteplase, tenecteplase can be used. Tenecteplase can be used alternatively. Tenecteplase administered at the dose of 0.2 mg per kg single dose IV bolus, not to exceed 25 mg. It has a similar safety profile, but has not proven to be superior or non-inferior to alteplase. So it is unclear whether it is effective as alteplase or not. So still, when we can't find alteplase, we use tenecteplase. So take home message: time is brain, time saved is brain saved. Reperfusion as quickly as possible to save the penumbra. The thrombolytic should be given within the narrow period of time, that is 4.5 hours. The benefit of treatment decreases continuously over time. Unnecessary wastage of time should be avoided. Even if we give a thrombolytic therapy and the patient is patient shows we do a CT angiography and the patient shows a last visual occlusion, we plan it for thrombectomy. We will not wait for the improvement for thrombolytic therapy post thrombolysis in a patient. We take the patient direct to thrombectomy without wasting our time. So there is no place for wasting of time in case of ischemic stroke. The chance for good outcome decrease progressively with time. So time is brain. I think we have to. Another thing is we have to create awareness about this to all the people, our patient. The time is brain. the term the patient uses heart attack. Similarly, this is a brain attack. We have to make them understand the severity of disease, the burden of the disease, the depression, the psychological burden, the financial burden to the patient party. So I think uh, this completes my lectures, and I would like to thank you all on behalf of my department, Neurology, Kathmandu Medical College Teaching Hospital, and from National Neurology Association. Thank you very much. Hello? 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 Hello?
Anand here. Can you hear me? So, switch on the left side, switch on your speaker on the left
Yeah.
side of.
Okay.
Yeah,
Okay.
Yes, right.
Yeah.
Can
Can
you?
you hear me now?
I finished my lecture, yes?
Dr. Dipesh,
Yes, sir.
thank you. Thank you for your very comprehensive review on management of thrombolytic therapy in ischemic stroke and its complications. I
Yes, sir.
think of all the challenges, one of the most challenging aspects of managing ischemic stroke is time constraint. Because the window period is so narrow, 4.5 hours only, we must be ready to manage the patient within 1 hour. That means door to needle time should not exceed 1 hour. So if we can do that, I think we can go a long way, and the benefit still outweighs the complication. So
Yes.
the next part of the session, I would like to ask Dr. Vikram Gazulal to take over and chair this session. Dr. Vikram, please. Dr. Vikram.
Dr. Bikram.
He's trying to say something, but we are not able to hear him, I think. Dr. Bikram, can you put on your microphone, please? Alan, can you check if Dr. Bikram's mic is muted?
If you search, I'm switching off and doing it on again.
Yeah, Dr. Bikram is the one who's sitting with the green background.
Yes,
Hello,
sir.
Dr. Vikram.
Can you hear me, Bikram? Dr. Bikram?
Audio on गर्नुहोस् actually on actually फेरि off गरेर फेरि on गर्नुहोस् त
I think so.
Dr. Vikram says that maybe in the center, from your center, that the mic has been turned off.
No, it is on. I can see that.
Dr. Vikram is on. Can you turn it off and on again?
Hello?
Yeah,
So there
Dr.
should
Krishna,
be.
we can hear you. It's
Yeah.
just give us a minute because Dr. Bikram is not able to speak anything.
Yeah.
For the audience, you can be ready with the questions. We'll have the question and answer section after Dr. Krishna's presentation. So in the meantime, we're trying to get back Dr. Bikram's audio. तपाईँको आएन Dr. Bikram audio आएन. The connection has been lost. Can you do something from the center, please? Okay. Dr. Krishna, can you hear me?
Yeah, I am here, sir. Yeah, yes.
Shall I go on? I'll ask Dr. Bikram to join us at the end of the session.
I think that will be okay.
Dr. Krishna is the next speaker. We're sorry Dr. Bikram could not join because of some technical error. Dr. Krishna Dhungana is DM in neurology and is an associate professor in the Department of Neurology in Kathmandu Medical College. So he shall be speaking on indication and contraindication of